Hello and welcome to today's webinar, Member Satisfaction, the Ripple Effect of Provider Data. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today David Cologne Margulies, Director of Customer Success at CAQH, and Ron Irwang, co-founder of De Facto Health. And at this time, I would like to turn the floor over to the speakers.
Thank you so much. And thank you all so much for joining us today for this engaging discussion around member satisfaction and provider data, a couple of topics that are very close to my heart and that I'm passionate about, and I know my friend Ron here is as well. Before we dive in, I thought I'd just give a quick introduction to sort of talk a bit about where I've spent my time in my career, and then perhaps turn it over to Ron to talk a bit about his career and where he's passionate. And then we'll turn to some of the key learning objectives for the day and talk through overall, what our roadmap is for this discussion today. So again, thank you all so much for joining. My name is David Cologne Margulies. I'm a Director of Customer Success at CAQH. I've been at CAQH for just over 4 years and really spent most of my time here partnering with health plans and provider organizations to think through those critical challenges as they relate to the administration and delivery of healthcare and how we as an industry can come together to sort of think through and collectively sort of address those challenges and create a better ecosystem for all patients. Prior to that, I spent about 6 years, and in total, I've got about a decade of experience partnering with healthcare stakeholders from across the spectrum, whether that be health plans, health systems, manufacturers, and other third parties, really thinking through the challenges around access to care, how networks are managed, and how products are commercialized and sort of deliver that quality experience for patients, right? If you want to talk a bit about your experience and sort of how today's topic relates to your passion in the healthcare space.
Hi, everybody. My name is Ron Irwang. I'm a co-founder of De Facto Health. I founded De Facto Health along with my co-founder TJ about 3 years ago, actually 3.5 years ago now. What we do is we query payers' provider directory APIs, and we have the nation's largest data set of healthcare providers and the insurances they accept. And we make that data available to third parties who use it to power in-network provider search capabilities, plan comparison, network analytics, provider directory data cleansing, a bunch of different use cases, some of which are directly related to members, consumers, and patients and finding care. So we've seen firsthand how data with errors can impact the member experience, and love to dig into that a little bit more as we get into the discussion. Funny enough, I used to work at CAQH and managed a couple of the products there, including the provider data and credentialing products. And so, I'll bring some of those perspectives into our discussion here today as well.
Thanks so much, Ron, and always great to have a chat with you. I really enjoyed my time collaborating with you while you were at CAQH, and since it's always wonderful to hear your perspective since you're able to connect all those dots across the health plan, provider, and member ecosystem. With that, why don't we just dive right into talking through what our learning objectives will be for today's webinar and sort of foreshadow a bit of the conversation, not getting too ahead of ourselves, but giving you a 30,000-foot view of what we want to accomplish today. So as the title suggests, everything we're going to talk about today is going to really relate to how data and the member experience come together and how us as stakeholders that help administer healthcare can think more strategically about bringing those two concepts together and driving the patient experience. The four, core components of today's discussion are going to really break down to a level setting conversation about what member satisfaction is, what data quality is, how those things are measured, and where the intersection is between those two critical concepts. Then we're going to explore what I like to call story time, or rather a scenario that nicely sort of lays out the provider data lifecycle and how the different stakeholders can influence the member experience. And really excited to get Ron's perspective on where some of those bottlenecks are and where we can drive a better patient experience as some of those stakeholders that have our hands on the levers, if that makes sense. And then we're going to move into a review of some cases or some examples of where we've seen some tremendous strategic efforts from different healthcare stakeholders, in particular health plans, as they think through how they can strategically enhance their efforts around provider data collection and how they can drive against those requests and needs of the members as they continue to evolve. And then lastly, we'll open things up to a Q&A where we'll review the questions that you put into the chat and definitely stick around to talk about all things member satisfaction, provider data. And if there are other topics that are related and close to your heart, we're more than happy to talk through it with you today as well. So with that, Ron, I wonder if it makes sense for us to start with a conversation really briefly about what member satisfaction is. It goes by a couple of different names depending upon what stakeholder you are and how you think about the overall end-to-end delivery of care. And then, just maybe a little wonky discussion about data quality, provider data, and the provider data lifecycle and where these things intersect. So with that, I'd just love to kick the conversation off by asking you, Ron, when we think about member satisfaction, right? How do you think different stakeholders, healthcare stakeholders, define and measure this key metric? I know when I think about member satisfaction, my mind goes straight to, member experience surveys that health plans might be sending out to their members to sort of gauge where they can improve their plan offerings and how they're managing their network. But, something tells me that this topic is much larger than that. So talk to us a bit about that.
I think we'll get to the formal frameworks and kind of systematic ratings of plans in just a second, but I'd like to start off with just organic member satisfaction and how that affects health plans as a business. So, if you think about, let's say, individual members and subscribers to an ACA plan or a marketplace plan, if they have a good experience, if they're able to get the care that they are looking for and at a cost that makes sense to them, they're likely to stick with the plan. Why change something that's not broken? Now, if they're unable to find care in a timely fashion, or let's say, and we're going to get into all the details around this, searching for uh, a a specialist within network and they're not able to get an appointment within a timely fashion, that's going to affect their member satisfaction, and they may be likely to consider other options in the next open enrollment period. Similarly, you've got groups, and they subscribe to plans as well. And if a critical mass of employees within a group plan sends complaints to the decision makers within that employer, there's likely to be some change in the future. So you've got the regular organic churn of unsatisfied customers or members, moving from one plan to another, from plan year to plan year. Now, David, you alluded to the idea of more systematic plan ratings and these member satisfaction surveys. We've all probably heard of Medicare Advantage star ratings and how surveys are issued to some sample of members to collect their feedback on the plan. And those really have an outsized impact on member enrollment. So as an example, 60% of MA enrollees are within plans that are 4 stars or higher. And only 1% of those MA enrollees are in plans under 3 stars. So, the vast majority of MA enrollees are really focused and will only consider those plans that have the highest rating. It's also got a huge impact on revenue. So analysts say that moving from 3 stars to 4 stars increases plan revenue 13 to 18%. So this is, dollars and cents ROI impact for member satisfaction and for these plan ratings. And I guess, I don't want to get too far ahead, but I'll just say real quick, member satisfaction is dependent on the experience that members have using provider directories in their search for care.
Really, really great context and helpful perspective as we think about the different stakeholders and how the push and pull of how, members are accessing care and the different types of stakeholders that are working with health plans to acquire those benefits. Think about, the experience that the patients and the members will ultimately have and sort of the business drivers and outcomes associated with that. Now, touching on, the Medicare Stars program and how that measures some level of the member experience, right? I wonder if we could maybe unpack that a bit more for folks who aren't as familiar. I wonder if there are perhaps some folks on the phone who are not from a plan that offers a Medicare Advantage plan, right? So when we think about the sort of components that the Medicare plan and or CMS thinks about when they go to measure some of these things, what are those key components? I know we've talked a bit about member experience, customer service. Obviously, there are some other components around outcomes and the actual care that's delivered. Wonder if you could share a little knowledge with the group about that today.
Yeah, and I guess I don't want this conversation to be too MA focused, so I'll just mention real quick, and I'll get back to your question, David. That there are other types of plan ratings across other lines of business as well. Some states have uh, Medicare stars like ratings for their Medicaid MCO plans. There's actually a rule in the works on kind of deploying that nationally. And then in addition to that, there are other third parties that rate plans like NCQA and JD Power. Even US News does some ratings around that. But specifically to your question around what are some examples of some of these member satisfaction measures, specifically within MA stars, so timely access to care is one. Another is around customer service quality. And then, of course, there are, care gaps. You've probably heard of these fetus measures. They identify gaps, and, plans are very interested in closing those gaps where they're able to identify them. David, do we want to go into how that relates to provider directory just yet, or do you have any other things you want to explore?
No, I think that's really right. I just wanted to sort of connect back both the sort of customer experience of when you access a directory, what are the different digital tools that are letting you access it, and are you able to navigate the customer service aspects, but not lose sight of the very critical clinical aspects, right? You touched on earlier around making sure at the bottom line that a patient that's a member that participates with a certain plan is able to find the providers with the specialties and that offer the specific clinical services that that patient needs, right? And making sure that that's accurately represented through those digital tools that they might use to access care, which I think dovetails nicely into my next question for you. And I think as we start to think a bit more about the data side of this, let's talk a bit more about the intersection of member satisfaction and actual data quality and what the provider data lifecycle looks like. Maybe you can give us some top line thoughts on that before we take a closer look at how that sort of touches each stakeholder.
I don't want to steal all of your thunder around the storytelling because there's some really good nuggets there, but I'll just mention very briefly some examples around those um, satisfaction members that, satisfaction measures that we had just discussed. So, like timely access to care. If a member is using a directory to search for a specialist, and either the information is incorrect, like providers are not at the addresses they're looking for, or there's a dispute on whether they actually take the plan that they're listed under, or they're not accepting new patients, or they're retired and not even practicing anymore. That those are speed bumps that are barriers for the member to be able to access the care they need in a timely fashion. Um, around, let's take, for example, surprise billing. So, members, let's say a member finds a provider they're interested in, and then they go get the care that they need. And then after the fact, they get a surprise bill from that provider because, gosh, that provider wasn't actually accepting the plan that the member thought they were. That's going to produce all sorts of member satisfaction issues and probably customer service complaints. So, related to customer service complaints, both not being able to find a provider using the directory, members will often call up the helpline and say, hey, can you help me find somebody? Or, having to work through all the issues around surprise billing after the fact. That's going to increase inbound call volume, and the member's not going to have good feelings about that. Um, and then, of course, the care gaps as well, because if a member can't find the care that they need, then that gap isn't going to be closed. So, it would behoove payers to be able to make access to those providers as easy as possible for those members.
Really powerful stuff there. And I think you're starting to allude to where the incentives and the drivers lie across different stakeholders, which I know we're really going to want to dig into as we think through some of these scenarios and use cases later on. I'd love to now turn to a conversation about data quality, right? And how data quality at the various points in the provider data lifecycle touches each stakeholder, and how there are, different rather themes that influence the quality of that data as it makes its way through the life cycle. So here we've got, a slide that I think tees up really nicely what that life cycle looks like between stakeholder types, be it the member, the individual provider, the group administrator. And since we know that we've seen a trend over the last several years of more and more solo practitioners moving into group practices due to administrative burden and burnout around the collection and management of this data. And then the health plan perspective, right? I wonder if we could talk a little bit now, in terms of when we think about the quality of provider data at various points in that life cycle, right? What kinds of common challenges do you see across the various stakeholder types? And are there themes that you'd call out?
Oh, I love this picture because it shows how every aspect of the healthcare industry, this ecosystem, has a hand in provider directory data accuracy and completeness. So all the way from the practitioner submitting the data to their practice, and sometimes it's somebody internal within the practice. Sometimes they outsource it to third parties that um, help the practice enroll their providers into plans and keep them attested enrolled. Then there's the plan itself trying to ingest the data from the practice and then publishing that data to the member through directories, third-party apps, etc. And actually, even the members have a hand because there are, those. Hey, do you see an issue? Do you see a problem in this directory? You have, as a member, have the ability to report that issue back into the plan so that it can get fixed. Um, I, in terms of common themes, there are there are uh, there are opportunities for errors and failures all along the way here because data has to change hands. It's got to be either manually entered, verified over the phone, transmitted via rosters, loaded in some way. And there are all sorts of things that can happen. The practitioner can be late in attesting. They can miss information that the group admin needs. The group admin or a third party that practice is outsourcing to may not have access to all the right information about the practitioners. Everything from what address they're practicing at to their office hours um, to their areas of expertise. That data and information exists somewhere within the organization, but it may not be directly available or accessible to the payer enrollment types who are making it available to the plan. And then, within the health plan, so many opportunities. We throw the word silo around a lot, but Uh, I think we need to make sure that it doesn't just become some type of throwaway cliche. These silos are real. They're actual different databases with different data that should actually all be harmonized and maybe should all be one system. But we understand from an IT perspective, many health plans are built off of acquisition after acquisition and all of these IT systems having to be integrated with one another. So, I'm empathetic to the fact that it's very difficult to bring all this data together, but that doesn't reduce the need to master and normalize the data in some type of centralized place. And then, of course, there's the uh, delivery of that data into the directory and how that's made accessible to the member and what that experience is for the member. And also, it's not just in the kind of the first class, health plan web property, which is the directory or their plan info pages. This data is being syndicated out to so many places now. All of these third-party doctor search sites and plan comparison sites use this data to help patients make the best healthcare decisions. So lots of opportunities for the data to go wrong, unfortunately, but that gives us a clue into where the leverage points are to make it right as well.
I think, you called out many interesting concepts there between technology, process, and people, right? Like as we've teed up on this slide. Couple things I'd like to add to sort of yes and you, if you will, if we're playing by improv rules here. I think there's so much also that when we think about the life cycle of the data and the people, process, and technology, that I think often it's easy to think through how a lot of that all starts at the provider, right? So as you mentioned earlier, you've got individual providers keying in data, writing data in on applications or pieces of paper that they're handing to their administrators, having to collect documents, sharing that continuously, right? And I think one of the challenges here, as we really think about this, and you kind of touched on it earlier when you were talking about, how members access the directory, and then also have an opportunity through member satisfaction and through engagement tools like that in the directory to provide feedback and sort of feed additional qualitative or quantitative data into the overall strategy to help improve the system. I think it's interesting to think about the life cycle of the data and how, while we might have a perception that it really begins at the provider, it's really an endless cycle, right? And so while you might have the provider and the administrator collating that data, they're pulling from various data sources, right? And from a technology standpoint, it's almost like this endless cycle where the provider or the provider group is storing that data somewhere. They have to continuously update it. They supply it through various exchange mechanisms, whether that be through, like you said, rosters, enrollment portals, how claims are being submitted, all these different sources that maybe are meant to solve different challenges and different problems, but are ultimately ending up on the other side of the fence with the plans, but not just the plans, third parties that are aggregating this data, working directly with the health plans or trying to offer something differentiated into the market, even separate from a direct relationship with a plan. And all of these different access points for understanding how to navigate care, but also as a provider, how to supply data and make sure that it's ending up in the right place to direct those patients to you. It can be an insurmountable challenge when that data is constantly being updated, shared across stakeholders, shared back, right? And updating the different access points that patients might interact with in different cadences and in different ways, right? So we're going to get into this a bit more later, but it's a really comprehensive challenge when you don't have interoperable standards that are making sure that the data is being standardized, normalized, shared across secure pipelines in an efficient fashion, and providing a feedback loop so that there is to the extent that we can create one, a source of truth, because so much of this data cannot be just identified from a authoritative database. Sure, you can go and validate that some provider has a certain specialty and that they're board certified, right? There might be by going to the state medical boards or to some other source a way to validate that. But if Dr. Jones practiced at 123 Main Street a month ago and was a PCP there, and in the last month, decided to move to a different state with their family and now is employed at a different location within that health system and isn't seeing patients at 123 Main Street anymore. Well, if the three aggregators out there that aren't plugged directly into the health plan but are scraping data from the internet and then presenting it into an appointment scheduling tool that a patient might try to schedule. I don't know how much experience you have with it, Ron. I know I've tried a lot of those tools to schedule appointments and then found out later when I called the doctor's office that the provider wasn't there anymore. It can be really challenging, and it's almost like playing whack-a-mole, trying to make sure that the right information at the right time is ending up in all of the places where a patient might access that care, right? And I know we can't index too hard on this concept, but I think it's so crucial to the conversation today. I wonder what your thoughts are on sort of like that wild west, if you will, of where all the data is popping up and how patients are using digital tools to try to access care.
It's a challenge because, as you've described, like you would wish that you could wave a magic wand and all of that data is harmonized. And well, gosh, in this third-party tool versus the payer directory versus the practice website, it is the same address, the same office hours, etc. But in the absence of having a universal source of truth that everybody agrees is the universal source of truth, it is a little bit of a Wild West phenomenon. Now you can try to get there by you described web scraping and AI. There are platforms and vendors out there who are doing that, and they can tell where there are differences between all of those different properties and identify them, and whether they have that feedback loop to all of those places they're scraping is an interesting question. I mean, at de facto, we query over 130 payers APIs, and we identify all the differences between their directories, and we try to report those back as well. So that's another way to get to it. I mean, there's some discussion around a national directory where the government establishes an authoritative source of truth and they declare it as such. So that might be a path forward as well. But I think there's a little bit of either wait and see, or the industry has to come together and do something together.
I think that makes a ton of sense. Either we as a industry can come together and try to solve these challenges through consensus building and strategic alignment, or in some cases, if we can't do that, ultimately legislation attempts to do that, right? And the government is sometimes well positioned and sometimes not, right? And so I think as we continue the conversation, right, I just want to spend a little time on the concepts around data quality, how it's measured and how we think about it. There are these 6 dimensions, right, that CAQH thinks about, accuracy, completeness, consistency, timelessness, uniqueness, and validity. We've spoken to a couple of these concepts. I don't want to spend too much time on this. We can share these slides with the audience at a later time. But Ron, at the end of the day, when you think about measuring data quality, right, this is perhaps a very wonky way to think about it. It's important that we're applying, core metrics like this. But when you think about it from a patient's perspective, what really is data quality and accuracy all about?
Are they able to get the job done that they are asking the director to do? Which most of the times is, can I, as a patient, get timely in-network care? If I can't, it's not accurate, or it's not complete enough, or maybe there aren't enough providers. You have to pick one or the other. The other thing I'll add to it, and I know we need to move along, is that I think we need to measure it consistently across organizations, because I've heard some payers say, well, gosh, my directory is 95% accurate, 99% accurate. And, is that reproducible? Can I take some methodology and measure your directory and find the same result? Or is that some proprietary method that you're using? So I think it's important across vendors, across payers, and across different government agencies that we measure it the same way.
Couldn't agree more. Sort of with that, I would love to turn things over to the audience briefly as we think through, what those levers are that we can use to influence member satisfaction, and what do we think in terms of provider directory quality really is the components that most affect that member satisfaction. So we've laid out, 5 options for all of you here. Number 1, or A, do you think it's difficulty finding in-network providers? Number 2, or B, is it delayed access to care? C, is it out-of-network surprise billing? Or D, is it poorer health outcomes? Or E, plan selection and retention, right? And when I think about this, I think that there are several different factors. We've touched on many of them today. But ultimately, I think they all kind of come back to the same sort of core challenge at the heart, which you just hit really nicely on, Ron, right? Which is, it's important that we are aligning the industry around how we measure data quality, but ultimately all of that has to be in service to how can we ensure that the patient is able to access the care that they need at the time that they need it, and that it's covered and at the lowest cost, right? That's ultimately what all of this is about. And so, I wonder, for those of you listening today, whether you think that one of these sort of overstates the others, right? With some of the results first coming in right now, it's looking like most folks on this call really believe that it's difficulty finding in-network providers, right? And so I think I could see, and this is how I'm thinking, that could easily cascade into delayed access to care, and then surprise billing when you access care not in alignment with the coverage that you have. But I have to be honest, I'm not surprised, right? Because I think A really speaks to that core challenge.
I agree. It seems like the remainder B through E really flow out of A, so it makes sense that many people picked A.
So with that, I think we're gonna keep trucking, and I see some really great questions coming in. Looking forward to answering those at the end. For the next part of our conversation, we want to tee up this story time, this scenario that I think really lays out some of the concepts we've talked about today. And so for the purpose of this scenario, we're going to talk through a patient perspective, a provider perspective, both from the admin that manages the exchange of data with the health plan, as well as the office manager that interacts with the patient accessing care. And then lastly, the roster manager, or the individual at the health plan whose job it is to manage the relationship with the provider organization and try to drive higher quality patient experience and member satisfaction through the directory and the primary tools through which the patient accesses care, right? So we've got Joe, who's the patient, Jack, who's the admin at the group, Susie is going to be the office manager, and then Chris, who's that roster manager. And so really quickly, Ron, I'm going to talk through the scenario. Once I get through all of it, I would love to hear your key thoughts on number 1, where are the bottlenecks in this process, in this scenario that I'm laying out? And then number 2, what are the opportunities for all of us as stakeholders to think about how to better align the industry and drive that greater member satisfaction, right? So I'm going to just use a scenario that leans a bit on rosters, because from what I've heard working with provider organizations and health plans, those rosters are really exemplify some of the data quality challenges, because those data quality challenges, they do exist with directly enrolled and credentialed providers. But when you're talking about managing provider data at scale across what could be up to a 10,000 practitioner practice, that's where the quality really goes downhill, and there's maybe some less alignment in the industry, right? So for this scenario, right, Joe is in his 60s. He just became Medicare eligible. He subscribed to a Medicare Advantage plan, Sunny State Health Plan, and he's looking to schedule his first PCP appointment, get all of his vitals checked, and make a wellness plan for the year ahead. As a part of this process, at the very same time, Jack, the admin at the provider organization, is getting ready to submit this month's roster to Sunny State Health Plan and update enrollments and provider directory updates, right? So Jack goes through and really keeping at the center of Jack's mission in terms of the marching orders he's gotten from his leadership. He needs to ensure that the data that's going over to the health plan is going to ensure that they are avoiding any sort of denial situations and able to establish and manage maximum reimbursement for all of the care that they're offering to their patients, right? So Jack putting the roster together and thinking about how he can ensure that any claim that's filed for a provider within the group at the different practice locations won't get denied, right? So he's thinking about submitting every single practice location within the medical group for each provider in the group so that there's no concerns around how those claims might be paid out. He constructs the roster. On that roster, Dr. Golden, who's a specific PCP provider within the group, is listed as practicing at 8 locations and accepting patients at 8 locations as a PCP. And the roster is then sent over to the health plan. Jack receives it, runs it through a roster automation tool. It flags a couple of concerns, specifically around Dr. Golden having more than 5 practice locations where he's seeing patients at least 1 day per week. Jack follows up with Chris and says, hey, Chris, what's the deal? Or rather, Chris follows up with Jack and says, what's the deal? My roster automation tool flagged a couple of these scenarios with Dr. Golden. I want to make sure that this represents accurately, the situation with the providers within your group. To which Jack responds, well, Dr. Golden is a part of this medical group. He has an affiliation as being employed by the medical group with all these locations. So you're good to load that roster. I want to make sure that it goes through as is. So then Chris says, okay, he processes the roster and updates the provider directory. As a result, Joe then looks in the provider directory, sees that Dr. Golden is loaded at all these different locations, including a location that's near his home. And so Joe decides, I'm going to schedule an appointment with Dr. Golden. Dr. Golden's going to be my new PCP, and he's going to help me get my health and wellness routine on track. So he calls the office. Susie picks up the phone. Joe asks, hey, can I get an appointment with Dr. Golden? And Susie responds and says, well, the time you're asking for on Tuesday, Dr. Golden actually doesn't see patients by appointment here as a PCP at that time. But however, we do have some other PCPs that practice at this location. Dr. Bronze is one that I could set an appointment up for you. It looks like Dr. Bronze participates with Sunny State Health Plan. So what about Dr. Bronze? Joe says, all right, let's get that appointment scheduled. Schedules his appointment. He goes in, he sees Dr. Bronze. Dr. Bronze, takes some blood work. Turns out Joe's cholesterol is a bit high, his blood pressure is a little bit high. So he leaves the appointment with the plan to move to a Mediterranean diet and maybe play pickleball a bit more to try to get some cardiovascular exercise in. But ultimately, what ends up happening is Susie submits the claim, and then ultimately it turns out that although Dr. Bronze is in network with Sunny State Health Plan, Dr. Bronze isn't in network with the specific plan offering, that Medicare Advantage plan that Joe is enrolled in. And so ultimately, as a part of this, although Dr. Bronze does practice at that location as a PCP, she is not a PCP in that specific plan offering. She's a specialist, the cardiovascular specialist, right? And so ultimately the claim gets denied and Joe has to pay for this episode of care out of pocket. He's very frustrated. He leaves a member complaint with Sunny State Health Plan. And then Chris has to go back to Jack and say, hey, what happened? Jack explains, I was trying to maximize reimbursement. Chris explains, that's not how we handle reimbursement. We actually do it based off of the contract. What I really need is to make sure that what I'm getting on this roster is accurate for the directory so that we don't have this happen, right? And so there are a lot of lessons learned from this whole process. This isn't always the most, common issue that comes up, but it is something that can come up when there are challenges with the context and the alignment around the standards of how that data is being exchanged and how the many use cases of the data is being applied. And so with that, I would love to hear your thoughts, Ron. Where were the bottlenecks in this process? Where were there opportunities for these different stakeholders to work together better so that Joe can ensure that he was getting the care that he needed at the time that he needed with the right reimbursement and coverage?
I will keep my remarks brief because if you let me, I could talk about this for an hour. But I think this story shows that there are issues on both sides of the industry, on both the payer side as well as the provider side. I think on the provider side, there's the uh, original sin, if you will, of the marching orders given to the group administrator on how to prepare the roster, which it's it's the right spirit, but it's kind of incomplete. It's, hey, you need to get these providers into network as quickly as possible and make sure that no claims are denied in the future. And there's this perspective that, well, that means you have to associate the provider with every single address. And we know this is happening. I mean, CAQH has certainly seen it and published about it. The government has analyzed that issue and has even uh, talked about that in some reports, that there are some big groups and big health systems that are just simply associating every practitioner with every address. And that explodes the number of directory errors. So that's one of the big original issues that had all of these kind of downstream cascading impacts. Um, I think the other thing that happened on the provider side is that Susie didn't confirm with Joe actually what insurance he had to the product level. Maybe she heard the carrier and said, okay, well, we accept Sunny State, but not this particular product. But she didn't go there and probably didn't even run an eligibility inquiry for Joe. So, I mean, those are things that she could have done as well. Also, it's going to be sad for Joe because he received a surprise bill, but he actually didn't use the directory to make that appointment with Dr. Braun. So the no surprises protections don't help him there, which is really, really sad. So I know I'm picking on the provider side a lot here, but on the payer side, I think one of the things that Sunny State could have done was made it clear to the group that, hey, you can associate this practitioner with this address, but have some kind of qualifying flag that says, well, they are affiliated with this address, but they don't see patients here more than once a month, or what have you. That would have solved a lot of the problems that we observed here.
I think you hit the nail on the head, right? And at the core of a lot of what you talked through, I'm really hearing industry alignment, right? Because if we're not as stakeholders doing the sense making of working with the other stakeholders in the provider data lifecycle to ensure that the data is being applied with the proper context, that best practices are being followed with the patient at the center of everything, right? Then we're opening ourselves up to this. And a great mentor of mine always described this challenge as sort of in the dark room that is perhaps the healthcare ecosystem, right? Each person describes the elephant in the room by the part that they touch, rather than turning the light on and having a discussion about the fact that there's an elephant in the room that we need to get out of the house, right? So I think you really hit it on the head there. Understanding that we've only got 17 minutes left, and we've got some really great questions still in the queue that I want to hit on as we get to the end here. I thought we can maybe quickly talk through another example, a case study, in where CAQH has seen some really interesting strategic efforts from health plans to think about this problem in a more broader context with keeping the patient at the center of everything, right? So I'm going to flash up here just quickly a case study that I think really nicely captures all of this around a multi-state health plan that was thinking about sort of the requests and challenges that plan was seeing in terms of what their members, what their customers were expecting, and particularly thinking about network adequacy and how that plan can ensure that they're investing in building out a network that serves the members and offers them the care at the time that they need it, where they need it, when they need it, and in with maximum coverage, right? Really well. And so what we saw was this health plan looking to partner with someone to identify those gaps in their network and come up with a solution for how to fill the gaps, right? And so what ended up happening here was the plan came to work with CAQH to try to understand, okay, we have gaps specifically in terms of our network adequacy in certain geographic markets and with specific provider types that we are hearing from our customers are an absolute need in terms of our network and the benefits that they access through it, right? And so they worked with CAQH to perform an analysis to figure out where their gaps were in terms of the total area of opportunity for practitioners in that geographic market. In this case, it was Texas, with that provider specialty of being an OBGYN, and thinking through how they could sort of develop a strategy to address those challenges. And ultimately, what they were able to do was identify an 81% gap in that piece of the benefits that they were offering in that market by zeroing in on specific zip codes, understanding what practitioners were available to think through contracting with, and then execute a targeted recruitment strategy to identify those providers and get them into contracting. Now, talk to me about what your thoughts are in terms of what is this plan doing right? Like, what could other plans learn from sort of thinking this way? And is there more that we should be doing as an industry to sort of boost initiatives like this?
I I think one thing this plan is doing right is that they are linking this concept of directory accuracy and network adequacy. They are inextricably linked, but oftentimes they are handled in two separate groups or focus areas within the payer organization. But they both support the members' efforts to try to find in-network care because directory errors are bad, but if you just don't have enough providers to begin with, then you're uh, even if you cleaned up all of the errors, you'd find that very quickly that hey, there's just aren't enough providers for the member seeking, in this case, OB-GYN. So I think that's what they're doing correctly. I think there is an opportunity for payers with all the transparency and the APIs to be able to know, hey, here are my gaps. Here are the providers that other payers are using to fill those gaps, and let's recruit them and bring them into network so that we can close those gaps. So I think that's great that they are not only linking network adequacy and directory, but also bringing forth the providers and adding them to their network so that patients can get the care that they need.
That's really well said, Ron. And so with that, what I'd love to do really quickly is take one last poll to sort of gauge our audience today. And then I'd like to shift over to some of the awesome questions that you all have been submitting. So I would really love to understand from you all, if you could just take a look at the poll on the screen, what percentage of member complaints are you seeing as due to errors in your provider directories, or in terms of provider directories as a whole? And I know Ron and I were sort of thinking about how we where we thought that these answers might land in terms of what this audience is thinking, but really interested to see what everybody thinks here in terms of what percentage of these complaints are really being driven by the directory themselves. I think in my view, it's probably up there, maybe not the majority of complaints. It's probably pretty close. It's maybe number two, right after some of the challenges with just the technology and the customer service involved, because I find that often when there are challenges with accessing the directory and understanding where you can access care, what's the member's very next step, right? They call the customer service line and they start to have a conversation with their benefits specialists at the plan to understand, okay, why am I having trouble finding the right provider? Can you just do it for me? Can you help me? Particularly with those older, sicker patients that maybe are more comfortable using tools like phone calls and customer support centers versus digital tools, right? And so what we're seeing right now in terms of responses, very interesting. I think number one, what in terms of the answers that are coming in, it's around 21 to 40% folks believe that those complaints are being driven by provider directories, right? Which has the majority here. And to me, that says it's maybe not number one, maybe it is number one, but it's definitely close to the top. Would you agree, Ron?
I see a little bit of a normal curve here between 21 to 40%, and then still there's a pretty significant number between 41 and 60. So it's probably right around there.
Yeah, makes a lot of sense. Well, I think this has been a fantastic conversation. We've really dug into the different stakeholders, the drivers of challenges with provider data quality and how that ultimately impacts the patient at the end of the day, which no matter if you're a provider, work at a health plan, work at a third party, or at one of these wonderful vendor platforms that's out there, at the end of the day, we're all patients first, right? So I think this has been a great conversation to make sure that we're keeping the patient at the center of everything we do, including the business, right? With that, I think maybe we can turn to some questions that have trickled in because I've seen a couple of really good ones. So I'm going to go ahead and just start reading from the first ones that have come in, and we'll publish a couple of them to the group. So number one, I see a really interesting question from Lakshminarayan. Sorry if I'm mispronouncing your name, but the question is, hello. As we all know, provider data is static from quite some time. Believe that it hovers around 70 to 75% accurate with the best of health plans. Is there governance that could lead to improved accuracy alongside AI that could lead to improved patient experience? And I think this question is really nicely ties into some of our conversation earlier, Ron, about what are the tools that are out there, but also is there an opportunity to really, wrap it all together and think about how we can set better standards for the industry?
Yeah, I agree that the best health plans are hovering around 70-75% accurate. If you had told me that a year ago, I wouldn't have believed it. But we've been starting to measure that at de facto across all of the plans that we're integrated with, and we are seeing some going there. It's interesting that the ones that are in that range, some of them are ACA heavy plans, and I know that there have been some interesting new requirements out of CMS around how many addresses are listed on a per practitioner basis. And I think that some of those requirements are pushing out a lot of the errors that were historically within payers directories and pushing some plans directories into that 70 to 75% accuracy. So I think that's great. AI, I think there's definitely a role for AI. It would be better if the correct complete information was submitted at the first go around rather than having to scrape a bunch of websites to do that. But that's what we have in terms of tools.
Totally agree there. And I think that sort of dovetails nicely into the next question that we have. Great question from Robert Combe. I'm going to just answer it via audio, but really the question here is around, a lot of this data being acquired through the credentialing process. And sort of like a question about, should we be putting a fork in the road? Does it make sense to keep leaning on credentialing events as a quality control checkpoint for provider data? I wonder what your thoughts are on that, Ron.
I have mixed feelings. So there's pros and there's cons. The pro for aligning it with credentialing events is, providers and their staff, those provider organizations, they're in a rhythm of having to do that to keep providers in network. So it's a nice checkpoint, as you say, or as the question asker had mentioned. That being said, you have to, and we saw this in the storytelling that we described before, but you have to make sure that the person responsible is incentivized, required, and equipped to deliver the right data. So if they've got access to the perfect directory data within the provider organization, that's great. And if their performance review says that the directory data that they submit to payers has to be excellent and over 90% accurate, that's great. But if they're not being told those things or equipped in that way, then it's just a convenient checkpoint and you're still getting the bad data. So I think that the two need to come together for us to really take advantage of that strategic checkpoint.
I totally agree. I mean, I think that the quality control checkpoints make sense, right? But I think at the end of the day, there's a part of this where at what point are you sacrificing the quality of the data while trying to create too many different input methods to collect the data, right? So you have to balance the burden on the provider or the data supplier along with the need for better checks on the quality of the data and thinking about the most efficient ways to collect that information and reconcile it. And so there are a lot of tools out there that are seeking to sort of apply additional checks to data that's reported by providers. But at the end of the day, if these requests and all these different use cases are so exhaustive, and we're asking providers to go to a million different places, and in organizations, right, provider organizations to submit data in a million different formats to different locations, the more that we try to incorporate other checkpoints to try to improve the quality, the more we're actually adding variables and complexity to it. And so I think it's a delicate balance.
Yeah, and it's just one more idea around this question. You could remove all the administrative burden around this by identifying the best source of data within the provider organization and then opening up a standards-based API that everybody can query so that you know you're getting the right data from the right source. Then you don't need those human administrative checks along the way. Payers or their vendors who are supporting them can just go ahead and get the data. I know that we're nowhere near that right now, but I can dream.
we can all dream, and that's the point of conversations like this, right? Because if we're not setting the bar high, then we're not going to be working towards a future that continues to keep the patient at the center of care as digital exchange of information continues to drive in complexity. Another question from the chat really quickly. Thank you, Chris Stefano, for your question. I'm in favor of having a consolidated outlet for healthcare payers and providers to access data. However, given the current challenges within healthcare, policy and business differentiation, it seems that individual payers and providers need to start the data consolidation process internally first. Based on your experience, where should payers and providers begin consolidating data at a division level? I wonder what your thoughts are
I
on that
love
one.
this. Yeah, because everybody's clamoring for a source of truth in the industry, but source of truth starts at home, guys. Like if you don't harmonize all of your data internally across all of your silos, then you don't have any chance of really taking advantage of an industry source of truth. You've got to master the data locally within your organization, in addition to advocating for some industry source of truth. So I think both things need to happen. So I love that question.
I mean, and I couldn't agree more. I think it's one of those things where, unfortunately, if we really want to solve the problem, we have to walk and chew gum at the same time, right? And what that means is, when you think about a provider organization, and if we go back to that provider data lifecycle, the sort of point on that life cycle where the provider enters their information or the organization collects it, right? Many times, depending upon the size and sophistication of that provider organization, you might have critical functions within the organization operating in silos. And you hit on this earlier, Ron, when we think about the health plan, but it's true on both sides, right? Where medical staff might be in charge of doing the credentialing and actually working with the practitioners to collect the data, populate the applications, get it submitted, work through the enrollment process. But then in addition to that, you've got a payer enrollment team who actually does the submission of the data, right? So the credentialing team goes out, collects it, does credentialing, and then the payer enrollment team actually has to consolidate that data with other sources, maybe from a directory standpoint, that may not be stored in the medical staff's database if they're using multiple systems. And when I've polled provider organizations that I've spoken to, more often than not, they use between 2 and 4 systems to store all the various data that needs to make its way into the pipeline over to the payer. And so working across medical staff, revenue cycle management or enrollment, and then the contracting team separately, really, it all needs to come together. It needs to come across systems. And then when it goes on the other side of the fence, you've got the exact same challenge with different siloed teams. And so I think we need to get it right at the source by having a tight process in-house at the provider and the payer side for how those teams collaborate and what their internal source of truth is. But then ultimately, that isn't going to make a difference if we're not creating interoperable standards where the data can be exchanged in a way where it doesn't get, the quality doesn't go downhill just through the telephone game, right?
Totally agree.
And so with that, I know we're right at the very end of the webinar. I want to thank you all again so much for your time joining us today for this conversation. Many more topics we could cover. Ron, I really wanted to get you with the vertical integration versus the non-integrated model question. Maybe that'll be a conversation for a later day. But just leaving you all with some final thoughts. At the end of the day, data quality is sort of one of those levers we can use, and measuring it is important. But when we think about member satisfaction, I think really it's about all the different components that come together to keep the patient at the center of delivering care and making sure that the patient can access care, the care that they need at the time that they need it with the coverage that they have. Any final thoughts, Ron?
I love what you said there. Let's focus on the patient journey, what they're trying to accomplish, in-network, timely care that meets their needs. That's perfect.
Wonderful. Well, thank you guys all so much again for your time today. Really appreciate the engagement and for you giving us this platform to speak. And we look forward to having many more conversations like this in the future. Have a great rest of your day. Take care.
And to our speakers, thank you for that great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again and enjoy the rest of your day.